DEVANU GHOSH ROY, cardiologist at PLS Hospital for more than 30 years now. Now, over the years, I have seen that atherosclerotic disease superimposed on thrombus formation is a major health problem in our country. So atherosclerosis can lead to myocardial infarction or can lead to a stroke. And probably these are now the commonest cause of death and disability in our country. So when a patient comes to us with an acute myocardial infarction, we prefer to go for a primary angioplasty most of the time. And when we go for a primary angioplasty, we need to load the patient with a dual antiplatelet drug. Earlier, we were giving aspirin and clopidogrel. But as we all know, clopidogrel has certain problems. So it is absorbed slowly from the gut. And the peak action comes about 4 to 6 hours later. Even if we give a 600 milligram loading dose of clopidogrel, the action will come only after 4 hours. But usually we finish up the procedure within 1 hour of the patient coming to the hospital. So that means after the procedure, there is a 3-hour gap, 3 to 5 hours gap, during which the patient is not protected adequately by dual antiplatelet drugs. So we need a drug which is actually acts faster. And today we are actually using Ticagrelor in all patients of acute coronary syndrome, because Ticagrelor, we get the peak action within 1 hour of injection. So that is a great benefit as far as patients with acute coronary syndrome is concerned, and for interventional cardiologists like us, where time is very, very important. Now, this Ticagrelor has certain added advantages also over clopidogrel. Now, Ticagrelor is a much more potent antiplatelet drug than clopidogrel. With clopidogrel, we can get maximum 30 or maximum 40% platelet inhibition. And this degree of platelet inhibition may not be adequate in many patients. And there is a possibility of recurrence of atherothrombotic event or stent thrombosis. So nowadays, we are preferring an antiplatelet drug which is much more potent. And the potency of Ticagrelor is such that we get 80 to 90% platelet inhibition. And because of this, there is less chance of recurrent atherothrombotic event or stent thrombosis. This will manifest as lesser ischemic events. Lesser ischemic events after an procedure, after an interventional procedure in acute coronary syndrome, and which will later translate into better survival. Now, the problem is when you are using Ticagrelor, there is a possibility, because of such high levels of platelet inhibition, there could be excessive bleeding. But as we have seen in the Plateau trial, luckily for us and for the patients, the bleeding risk of Ticagrelor is not more than that of clopidogrel. So when you replace clopidogrel by Ticagrelor, you get a much more potent antiplatelet drug, but not at the risk of additional bleeding risk, increase in bleeding risk. The mechanism we know of P2Y12 is a P2Y12 inhibition is the same as that of clopidogrel and Ticagrelor. The mechanism of action is same. But remember, then when you are using Ticagrelor, you should actually use a lower dose of aspirin, that is 75 milligram, and not 150 milligram. This lower dose of aspirin is also may translate into lower bleeding risk, because we know now today that aspirin is probably a very important cause of bleeding in these patients. So lower aspirin dose is preferred, and that is also recommended. And because of this, all the guidelines today actually say that if a patient of acute coronary syndrome comes, as per the guidelines, we should prefer Ticagrelor over clopidogrel. And that is what is being practiced all over the world. Now, Ticagrelor has other advantages also. We know that because of some genetic variations, some patients may be resistant to clopidogrel. And if they are resistant to clopidogrel, then they are basically on one antiplatelet drug, that is aspirin. And this will actually lead to stent thrombosis or recurrence of ischemic events in the heart. But such problem is again not there with ticagrelor, where whatever be the genetic buildup, ticagrelor is always active in every patient. So overall, ticagrelor, as we now understand, is a much better drug than clopidogrel in acute coronary syndrome because of increased potency, because of quick onset of action, because of better potency, and lack of genetic variations affecting its activity, and finally, the no increase in bleeding risk as compared to clopidogrel. However, there are certain risks of or side effects of ticagrelor which we should keep in mind. There could be sinus bradycardia or sinus pauses. And second thing is that there could be some cough. And this cough is because of an increased level of bradykinin. But this bradykinin may actually also be beneficial in acute coronary syndrome because of vasodilatation. So we actually try to give ticagrelor in every patient, and as it is beneficial and as it is per the guidelines. So thank you very much.